Hi, and welcome to another edition of At the Table with CASA, the podcast where we bring together the people, policies, and ideas shaping the future of care at home in California. It's presented by California Association for Health Services at Home, with generous support from Access. From home health and hospice to private duty care, Access helps organizations simplify operations, improve compliance, and deliver exceptional care. You can learn more at access.com. That's AXXESS.com. My name is Mark Wilson, and today we're going to discuss an issue that impacts providers, hospitals, payers, families, and perhaps most importantly, some of California's most medically fragile children. Private duty nursing has been a long-standing priority for providers and advocates across California. And as the budget negotiations continue in Sacramento, there appears to be, some growing momentum behind the efforts to increase Medi-Cal funding for these critical services. And as a lot of you know, that matters a lot because PDN allows medically complex children to receive skilled nursing care at home rather than having to remain in the hospital unnecessarily. According to a recent analysis, increasing support for PDN could save California approximately $175 million annually. So spend more to save more. We'll get into that in a minute, all while helping children and families achieve better outcomes. So what is the problem? Why can't we just get it done? For me, this discussion goes, I think, far beyond reimbursement for providers. It's about workforce. It's about access to care. And it's about whether California is willing to invest in a service that many believe improves care while reducing cost. Joining us today at the table are three individuals who've been deeply involved in this effort. First, Terry Henning, who's VP of Government Affairs from Aveanna Healthcare, Rand Martin from MVM Strategy, and Peter Callison from Clear Advocacy. Thank you all, first and foremost, for being here.
Thanks for having us.
Thank you.
Peter, if you don't mind, I'd like to start with you.
Sure.
CASA and lots of others have been advocating for PDN rate reform for years. Why does this year feel different? And what are you seeing in Sacramento that would give you some optimism?
It's a multi-part answer. For one, private duty nursing has been devoted in a single-focused manner on this issue and has done something that is unique for those who are in the Medi-Cal space who are seeking reimbursement increases. I don't want to go off on too much of a tangent, but it's important to the point. California's budget is done on a zero-based system so that a dollar spent today, even if it saves $2 next year, that savings cannot be scored in the budget. So that's always been a challenge for providers to successfully execute rate increases because it costs more money this year to spend. What the Private Duty Nursing Coalition that Aveanna has been just an amazing partner in, that CASA has helped organize and lead, several years ago, it identified and executed a study that was conducted by two of the most respected budget experts in California, David Panish and David Maxwell Jolly. And this study quantified that the savings that the state would accrue by increasing the private duty nursing reimbursement rate would become cost neutral within 8 months and would start saving money at 8 months and 1 day. And that study's not new. We've had it for a couple of years. And going back to answer your question more directly, the existence and continued use of that study has been an amazing leverage tool to distinguish private duty nursing from other traditional Medi-Cal rate increase requests. Secondly, the entire coalition has partnered in a very positive, effective way to conduct not just your traditional lobbying activities, but to do social media, public awareness, local activities, other elements that are important to a successful strategy. So One of the other things, and this is kind of counterintuitive, is that the cuts that are coming down from the federal government in a couple of years through HR1 are so significant and so potentially damaging to the state infrastructure that decision makers this year have to be more creative in coming up with ways to take risks, to potentially save money later when there's cuts coming that might be useful this year.
Interesting. Um, so the Assembly has proposed investments, I understand, in PDM, and the Senate appears to be incorporating PDN into broader home and community-based care discussions. Is there any significance at all that both houses seem to be moving in the same direction? Does that give you optimism, hope?
I would say that the inclusion of the rate increase is significant because both houses agreed and it demonstrates legislative recognition of need. The challenge now is that the budget negotiations are beginning their final phase, and it is now, even though the legislature has agreed on a two-party deal between the Assembly and the Senate, they're now entering the governor into the negotiations, and that's a different discussion entirely.
Rand, let's go to you. Let's talk about economics for a second here. Providers are often told that there's just not enough money. We just don't have it. Yet this proposal is suggesting that spending more, if I have this correct, spending more could actually save California money. Could you just walk us through that real quick?
Sure, Mark, I'm happy to. And, it goes back to what Peter was just talking about. The study that we commissioned from California Health Strategies, the two Davids, about 3 years ago, actually got to that question specifically. So they really wanted to be able to show that the cost of housing a child with complex medical condition in a hospital was far more expensive than moving that child to their family with a nurse coming in 8 to 24 hours in the most severe cases to provide health care in the home. And the conclusion of that study was if you compare average hospital cost per day, anywhere from $7,000 to $10,000, to the average cost of home health care for a child with complex medical conditions at 662, give or take, dollars a day. I mean, it does not take an economist, a budget crafter, a scientist,
Mhm.
um, any time at all to realize that that is going to be a massive savings. And I think that early on in our discussions with the legislature, as far back as 3 years ago, there was some recognition of that reality. It took us a long time to get the administration to recognize that as well. Not to recognize it, but as Peter was describing, they are more concerned about the budget year than they are about the out years. And the savings in year 2 or year 3 doesn't matter as much as the cost in year 1. And that's the hurdle that we've been trying to overcome with the administration. We don't know yet whether we have, but the fact that both houses have agreed to do it, and both houses have even built on what we brought to them relative to PDN to this bigger Be Home Soon California proposal that started in the Senate 2 weeks ago, was adopted this past week by the Assembly as well. That it is far more cost effective to make sure that people are in the least expensive but still quality environment possible.
So let
Um,
me ask you, do you think lawmakers then are starting to view PDN less as providers asking, for more money and more as a
Mm.
cost containment strategy?
I think that has helped them this year in making the argument. There has never been a doubt in the mind of the legislative leadership
Mhm.
on the health side that it is a better thing for the child and the family to
Mhm.
be in the home. Um, it is that has been driving some of the folks like Senator Menjivar, who's
Right.
the chair of the Senate Budget Subcommittee on Health, really driving her for the last 2+ years to be our champion on this.
And
But they have been supported that perspective with this cost savings argument as well, and has, as I've said with this Be Home Soon California proposal, expanded it into other kinds of care for different populations, seniors and other people with disabilities.
I'll just add to that, if I can, that more than 1,000 medically fragile children are waiting for in-home nursing services today, and many stay hospitalized unnecessarily for months and in some cases years because no home nurse or not enough home nursing is available. So obviously this is devastating news for the families and, as both Rand and Peter have emphasized, extraordinarily expensive for the state. Investing in PDN allows us to hire more nurses, retain more nurses, fill more shifts, keep more children home, and avoid unnecessary hospital stays, ER visits, and a whole lot more.
Yeah, actually, that's what I was going to go to next with you, Terry, is, what's happened to PDN capacity over the last several years, and how difficult has it become to retain or to recruit and retain nurses for pediatric private duty care?
Well, that's exactly right. When Medicaid reimbursement rates remain too low or fail to keep up with the cost of care, it just becomes increasingly challenging for providers to recruit and retain enough nurses to fill enough shifts to keep the children at home where they belong with their family, and which of course results in the cost savings we're talking about. It's been quite a few years since the last increase. We saw some immediate benefit from that increase with increased filled shifts, and we've been challenged since that time, and particularly starting with COVID. But we haven't seen an increase since then, while costs of care, inflation, wage pressures continue to rise.
So let's stay with the hospitals for just a second. Your hospital capacity. What does the delayed discharge mean for hospitals who are trying to manage the capacity? Do you have any sense of the numbers
I
on
mean,
that?
I think if someone else can jump in too, but I think that's exactly that is another critical point to make. We are part of the continuum of care. Every part of that continuum has to be well supported and adequately funded in order to provide the services that we need to provide. So when hospitals can't discharge patients, it prevents or limits the ability for other patients to receive the necessary care in the right location at the right time. And so it's really sort of all connected.
So the idea that improving access to PDN isn't just about home care, it's about
Right.
relieving pressure on hospitals.
Uh-huh.
Peter, are legislators understanding that connection?
Well, I think that the fact that the legislature, both houses, supported PDN this year in different ways. The Assembly supported PDN directly and explicitly and exclusively. The Senate supported PDN through a broader umbrella called Be Home Soon California, but specified only private duty nursing. So this really is a point where we are no longer asking whether legislators and policymakers understand this issue. The question now is whether this proposal can survive the budget negotiation process.
Terry, let's go back to workforce for just a minute. If rates were improved tomorrow, what changes for providers right away?
Well, we become increasingly competitive in the marketplace to hire and retain more nurses. Um, the rate increases that we are so appreciative to have as part of the budget process so far would make a big difference almost immediately in our ability to be more competitive in the marketplace.
I would further point out to what Terry's just saying. We're talking about a pretty sizable rate
Uh-huh.
increase, 40% rate increase from what it is now. It's currently, was it Terry, $44.12 for private duty nursing, and we would be up to $62 under this 40% increase. So yeah, the numbers are large,
Uh-huh.
but you compare those numbers with the numbers of unnecessarily spent money in institutions, and it just begins to make so much more sense.
So it's a recruitment and retainment
Yes.
issue.
Hmm.
Um, so would you consider this to be a workforce investment, really?
Oh my gosh, yes. It is. It is a tremendous, or will be a tremendous workforce investment.
So I have to ask, and I'll be frank with you, I don't often get to Sacramento to see the process working. I've made a couple of lobby trips with CASA, in past years. Um, Where exactly are we at in the budget process right now, today?
So we have some very defined dates in the law relative to moving the process forward. June 15th, which is next Monday, is the date that the legislature must pass a budget by midnight of that day. Otherwise, they don't get paid. The other absolute date is midnight on June 30th because a new budget has to go into effect on July 1st. Those are the only two dates that are unmovable. Um, but what happens between June 15th and June 30th is very much like a maelstrom. The budget gets passed, but there's so much that happens afterwards. In fact, the budget is built, the budget itself is a core part of this process, but surrounding it are dozens of what we refer to as trailer bills, which are all the policy decisions that have to be enacted in order to implement the dollars that are in the budget. And many of those things are still not finished yet. PDN, we have not even seen language yet relative to how it would be written into the law. And from a bigger perspective, that Be Home Soon California has not been written into the law. So between January or June 15th and June 30th, we're going to see a lot of that. The other thing that we may see are some changes to the actual numbers. And so by the time we get to June 30th, there may be what we refer to as a budget junior, which is the budget again with some hopefully very modest changes to the actual numbers. But everything is done and signed and goes into effect on July 1st. Most everything. I shouldn't be so absolute as to say that because we do have some things that occasionally trail beyond that. But for the most part,
So what I'm hearing is there are still some hurdles to overcome.
Yes, I would add that this budget that we're discussing is an agreement between the Assembly and the Senate. It is in response to the budget the governor revised in May, called the May revision, which is his budget, and that is his starting point in the negotiation. The two houses of the legislature conducted their own process to identify what are their priorities and what are their responses to the governor's budget. They then coalesced around what this proposal is. This proposal is a two-party proposal, and it needs to be a three-party proposal to be successful. So there are much larger issues that are in the budget than private duty nursing, unsatisfactory immigration status, the managed care organization tax. These are just the healthcare ones. There's taxes. All of these are items of conflict between the two parties that have agreed to the budget and the governor, and the horse trading has begun. So inclusion in the budget, our inclusion in the legislature's budget, it's a necessary step to be competitive, but it's not the ultimate step. We still have a long way to go to fight to stay in this because the budget negotiation process has entered, let's call it, for lack of a better term, the souk or the Moroccan bazaar phase of the budget negotiations. And we know more today on June 12th than as far as what is happening in the process, than we're going to know until the final budget is done, because it is being done at levels that are very, very secure and largely between the legislative leadership and the governor's administration.
You can call it what it is, Peter. It's secretive.
Yeah, it is.
Okay. This is for all three of you, and then I want to go to Terry for a question. What you were just talking about takes me to grassroots advocacy, and what can providers out there do? What can I do to support this, to keep it moving forward?
Well, I think the easiest thing for people in the community to do, citizen advocates for want of a better term, is to reach out to the governor's office and encourage him to support private duty nursing. And there is a place at gov.ca.gov where you can enter your perspective on something and
Who
ship
looks
it
at that?
Pardon?
Who looks at that? Who's checking that on a daily basis? Do we know?
Well, there are a lot of different people who are involved in that process. There are health people in the legislative affairs unit in the governor's office who are paying attention to this. Some folks in the Department of Finance are paying attention to it. Um, but like everything, when you're lobbying state government, it's the volume that speaks larger than the individual messages. The volume of responses from the community that
Yeah.
speak larger.
Okay.
The legislature has spoken, and it's now going to be conflict or a negotiation between the legislature and the administration. So Rand's point is spot on. The governor's office needs to hear this is a priority because everybody is getting hammered right now in terms of grassroots citizen advocates. There are some hot issues. So we need to be competitive, and they need to know that this is important. And I would also add that because the legislature has supported us, that those individuals who want to take that extra step to thank their legislator for supporting it is a reminder for them that this remains a priority, because things get really weird in the final days and hours. And things that were looking competitive all of a sudden maybe for whatever reason, they start fading a little bit. And then the dark horses that are seemingly long shots, start coming on strong. So it's important that we continue to cover thank our friends and advocate to the administration.
I need to step down for just a minute here. We'll get back to the conversation. I'll get back to my question for Terry here, but I want to make sure that we are thanking Access, as they are sponsoring this episode. Access is a leading global technology platform for healthcare at home. Whether you're managing home health, hospice, palliative care, or private duty services, Access delivers innovative solutions designed to streamline operations, support compliance, and empower caregivers to focus on what matters most. And that, of course, is patient care. Trusted by thousands of organizations nationwide, Access is helping shape the future of care in the home. To learn more, visit access.com. That's AXXESS.com. Okay, back to the conversation. Terry, actually, you know what? I'll open this up to everybody because I think you all bring with you a different viewpoint. You come from different areas. Let's start with Terry on this one. If California successfully makes this investment, look into your crystal ball if you could. What does success look like, let's say, out a year from now?
Yeah, I mean, I think obviously we've talked about some of these numbers already, but if more than 1,000 children are waiting to come home or not receiving the care that they need, we will make a significant dent in that number. And so more children, more families will receive the care they need and the support they need to allow the children to remain home with their families and in the community. And of course, it goes without saying, and I know we've said it a few times already, it comes at a significant cost savings to the state. And so it helps to be one step towards some Medicaid savings at a time when Medicaid spending and costs are so in the spotlight.
One more for you, Terry, because it just reminded me, are there any particular metrics that a company like Aviana is looking at right now? Any metrics that you're watching, like, I don't know, reducing utilization or anything like that?
Sure. We pay very close attention to the number of children either on wait lists in states or waiting to come home. And that's often discussed at the statewide level. So through the association in terms of statistics, we certainly look at authorized hours versus filled hours, missed shifts. I mean, when children aren't receiving the care, one thing that's really unique to this population is that when they are not receiving the level of care that they need and the consistent care that they need in the home, they are hospitalized far more often than certain other populations who still need care at home. But the level of medical need and medical acuity of some of these children is so high that they need that skilled nursing care at home to remain safely at home and not hospitalized or required to live or in a long-term care institution.
Yeah. Any advice you would have for providers out there that listen to this?
I mean, we support, there's so many providers who are already actively engaged in the advocacy efforts that, I thank everyone who is. I encourage everyone to continue to do it. There are you touched on this a little bit with Rand and Peter, but there are so many families out there who really want to share their stories. We try to help them share their stories whenever whenever we can, but we also encourage them to reach out directly to legislators and the governor's office to share their stories. I mean, I think one really critical piece of all this is that we need to remember that we're talking about people. We're talking about, in this particular case, children who are, have highly complex medical needs. But that's not all they are, right? I mean, these are really remarkable children. Any legislator who's willing to do a home visit, we support and try to facilitate, because there's just nothing like seeing who these patients really are, how they are with their families, the support and care that they receive in their homes. These are not patients laying in beds. They are children going to school when they have the nursing care they need. They are children leaving their homes and going to parks and living with their siblings. One little boy that we provide services for is nonverbal, needs tracheostomy care for a safe airway. He has a J tube for nutrition. And the photo that his mom shared with us was his backpack carrying his feeding pump around. That kid's on the move. She said he's always on the move. So I just think it's really important, anytime we get the opportunity, to talk about who these children are, who these families are, and how much these services mean to them and their ability to live real lives, meaningful lives.
I guess it just goes to show that there's nothing like a story to get across a point. You can talk data all day long, you can talk numbers, but stories like that matter. And thank you for that, Terry, because you've just reminded me of that.
There are thousands of them across the state and across the country.
And maybe that's advice for providers out there. Rather than talking about numbers, tell your own stories from your own communities. And I think that affects people, more than anything. I haven't forgotten, Rand and Peter, look in your own crystal balls, um, and and tell us what a year down the road looks like if we get this thing done.
You mean if the governor, if it's agreed to and it's signed?
Everything goes the way it's supposed to go.
Well, that'll be champagne popping time.
Okay, we're all drinking.
Or it could be sparkling cider, but
okay.
Well, I think, Mark, beyond the champagne popping, I think it's going to be necessary for CASA and Aviana and others to stay on top of this going forward. This issue is going to get much, much better for these families and for these kids, but it's not going to go away. And a year down the road, 5 years down the road, we're going to have to see how it plays out and whether we have had the demonstrable change to the waiting list that we anticipate, and be prepared to come at this again if necessary. But we need this first really huge step to make a big change in the delivery of these services, and then stay on top of it, so that we don't lose momentum from what we've been able to achieve the last couple of years.
Okay, I'm going to go around the table. One final question for all of you, and hopefully I have these numbers right. If California invests, is it $62 million?
Yes.
Okay, and that's supposed to save $175 million annually. If it improves outcomes, if it reduces hospital utilization, if it supports families, strengthens access to care at home, and again, going back to what Terry was just talking about, helps children, what is the argument against it? Peter?
it's a straight fiscal argument that is being driven, frankly, by the Department of Finance within the governor's administration, which is responsible for the nuts and bolts of the budget. And the fact is, it costs more money in this budget year, and that money has to come from somewhere else. And historically, The governor's office, because of the Department of Finance, has been harder on this issue than the legislature has. And the argument is a straight fiscal budgeting argument. It's not on policy.
Yeah,
Terry, anything to add to that?
And I would say that the benefits, both short term and long term, far outweigh any costs. And that is both from a purely fiscal standpoint, but also, just as importantly, for these patients and families who deserve to live lives of dignity and with their families and in their communities.
Rand.
I would just add, and really kind of echoing what Peter said, it's always a challenge, and Peter and I have been doing this for more than 4 decades, so we know it far too well, and we've seen it through so many different administrations. The perspective of the Department of Finance has never changed. What it costs in the budget year is all that matters to them. Even if you can make the most compelling argument possible about the savings in the out year, they just can't get past June 30th of the following year. And that's always been a challenge, whether it's in education or healthcare or in the environment. It's just something we all have to live with and make the best case. One of the things I think helped us a little bit with the administration is that we were able to demonstrate cost savings within the budget year. This is not just an out year cost savings, that in month 8, and this is based on the analysis done by the 2 Davids, in the budget year by month 8, we will start generating the savings to the state. So they don't have to wait until the out years to start seeing those. That helps. That helps.
Okay. Well, listen, thank you. You're all tremendous people. I've learned a lot from this conversation. Our thanks to Terry Henning from Aviana Healthcare, Rand Martin from MVM Strategy, and Peter Kellison from Clear Advocacy for joining us today. This is exactly the kind of conversation that matters to providers across California because it demonstrates how policy decisions made in Sacramento directly affect access, workforce, operations, and most especially patient outcomes. And in our conversation today, those patients are children. If you'd like to learn more about CASA's advocacy efforts, visit casa.org. And thanks again to our sponsor, Access. See them at access.com. My name is Mark Wilson. Please like us. Please love us, actually, but like us and share this if you've enjoyed the episode. Thanks again, Peter, Terry, Rand, appreciate you. Thanks for listening to At the Table with CASA, everybody, and we will see you next time.
Thank you.
Thank you.
Thank you.